Thank you, Clementine. Good morning, everybody. My name is Sarah Thompson, and I work as a Senior Health Financing Specialist at the WHO Barcelona Office for Health Systems Financing. It's really great that you were able to join us today. Thank you so much. I'm here with Maya Matthews, who's the Head of Unit for Performance of National Health Systems in DG SANTE, and we are very grateful to DG SANTE for supporting the work on financial protection, on affordable access to healthcare that we do in EU member states. Thank you for joining us today, Maya. Without further ado, I'm going to hand over to you for your opening remarks.
Thank you very much, Sarah, and good morning, everyone. I'm really delighted to welcome all the participants. We've had a huge interest from this webinar, so I think there's high hopes from everyone, including me. This policy dialogue is dedicated to the topic of affordability of healthcare. And as Sarah said, this is one of the deliverables of a project that we fund through the EU for Health program. And we're very glad that the WHO Barcelona Office is being so active, and we're very excited to see more of the deliverables from this project. As you all know, I'm sure, and are interested in, affordability of healthcare is a key issue and a key component of access to healthcare. And this is one of the key principles under the European Health Union. The European Health Union is basically the different policy initiatives that the European Union is working towards to improve the sustainability, resilience, access to health systems, and for countries to be better prepared for the next health crisis. As all of you, I'm sure, know, early access to healthcare is key. Without early access, you get into this vicious cycle where people delay access, and then inevitably the costs are higher. So that's why we are really interested to know about affordability. What are the different issues? What are the barriers? And of course, what are the solutions? And that's why this policy seminar, if you like, is really the first step for us to see and to go into more granular detail about what's out there, what data is out there. That's why, in a way, we funded this project, because we felt that there was a huge need to really provide coherent and robust data on these different important issues about access and affordability. Access to healthcare is multidimensional, and the barriers to access can be found at the levels of individuals, health service providers, and the health system itself. Access to healthcare is also affected by public policy beyond the health system, especially fiscal policy and social protection. So I think that's also something very important to be aware of, that we're not acting in isolation, that we need to find all of the different connections about affordability. In fact, the most recent EU Silk survey in 2022 showed that 2.2% of the EU population and 3.2% of those who claimed that they needed healthcare had an unmet medical need due to cost, travel distance, or waiting time. Data showed bigger challenges in Greece, Latvia, Romania, and Slovenia. Data also interestingly showed that cost was one of the most important factors behind self-reported unmet need for healthcare in the EU countries. So again, this issue about cost and affordability is really one of the cruxes that we need to unpick and understand better. And I'm sure, as you're all aware, the cost of healthcare can have a disproportionate impact among different groups of people. We've seen that the difference between the income quintiles is really quite stark in many countries. From the survey, again, we note that Estonia, Greece, Finland, and Latvia, Portugal, and Romania have some of the biggest disparities regarding the unmet medical needs. We also know that 15% of healthcare is paid from household out-of-pocket spending. And under universal health coverage, we hope that will change. Households in Bulgaria, Greece, Lithuania, Malta, Portugal, and Latvia contribute heavily to healthcare budgets through out-of-pocket spending. And of course, this may place an undue burden on the poorer households who have less liquidity and undermine financial protection. So how does this feature in the EU policy agenda? You might ask. So Europe, as you know, has promoted for a long time the importance of a strong social protection system. And when we say social protection, we include health coverage, health insurance. That's why the European Pillar of Social Rights Action Plan, adopted in May 2021, reaffirmed the commitment to put people first in Europe's recovery from the pandemic. It defines specific targets and initiatives around its 20 principles to ensure more effective implementation of the pillar. And Principle 16, which is the access to healthcare, the action plan calls for a stronger focus on persisting challenges in accessibility of healthcare, with a special focus on vulnerable groups. Because, as I said earlier, vulnerable groups bear the heaviest burden for shocks. We saw that in COVID, that those who were already vulnerable were impacted further. And we also saw this in the economic crisis, where austerity particularly targeted and was hard hit on vulnerable groups. So while the COVID-19 pandemic drove more resources to healthcare systems and raised, I would say, the spotlight on health systems and especially the resilience of health systems, I don't think we can be certain that this will continue. And that's why webinars such as this are so important, to raise these issues and to continue the momentum towards ensuring that health and health systems continue to be in the spotlight. So it's against this backdrop that under the EU for Health programme, the European Commission funded several projects which look towards access and affordability of healthcare. And our aim is that these projects, which I will quickly go through, will trigger more targeted policy solutions and help the member states to really define and put in place projects to ensure universal health coverage. So today we have a chance to learn from one of the key projects, this one today. And we really hope that all the work that the WHO Barcelona Office is doing will help to sustain and defend the key role that financial protection plays in ensuring universal health coverage, but also the resilience of health systems. Another ongoing project, which I would like to share with you, is in collaboration with the European Commission's Joint Research Centre, where we are looking at the metrics to assess the role of in-kind health benefits, so health insurance, for example, in reducing poverty. So we have data on how pensions and how unemployment benefit can mitigate poverty, but we don't actually have the data or the methodology to show how important health insurance is, health coverage is, in terms of keeping people out of poverty. So this, I think, will be a very important outcome, and I hope that it will help many member states and also all the stakeholders to be able to show the importance of having a good health coverage. The third action that we are funding is providing developing guidelines to member states on how to overcome barriers in access to healthcare for people with disabilities. We've seen that the unmet medical needs for disabled people are twice higher than the average. So we really need to address this issue. And this is also a specific deliverable of the EU's disability strategy. I would also like to stress the role of the European semester in improving access to healthcare. The European semester process advises and recommends to member states specific reforms to secure the EU's long-term prosperity, but also fairness in society. And we have regularly encouraged member states through country-specific recommendations, they're called, to reduce out-of-pocket costs for healthcare, ensure more equal distribution of services across territories, improve primary care. As I said, the early access is key, address staff shortages, which, as many of you know, is becoming more and more acute, as well as reducing waiting times and looking at the organization of services and new models of care. Complementing this, as part of the EU's action to build back better from the COVID pandemic, the EU's Recovery and Resilience Facility was born. And this is a 700 billion euro package, which provides member states with funds to, as I said, to recover, but with a very strong slant on resilience and green transition and the digital transition. And each country of the EU has a recovery and resilience plan, which explains how they will use the funds. And every member state has a component or actions related to health investments. Several of these actions in these different plans target barriers to access to healthcare. For example, the Recovery and Resilience Facility is going to be used to further implement the basic care guarantee in Finland, and also the consolidation of the NHS reform in Cyprus, just to give you some examples. So what is our objective today? Today, we are really delighted that the WHO colleagues will present to us the method they are using to develop and measure financial hardship related to the use of healthcare. And we really hope that this work will provide valuable information on incidence, distribution, and drivers of financial hardship caused by out-of-pocket payments, by income level, and other household characteristics. Getting data and evidence on financial protection is absolutely key, and I think this marks a very important landmark. But more importantly, we need to use this data. So my call to all of you listening today is really that this is not the end, this is the first step. It's an exciting step because I think through this project, we will learn a lot, and we will also gain a lot of robust data. It's a great opportunity for all of you to engage in this. And this was really the essence of this project, was to guide member states in improving the design of healthcare coverage. So I'm really looking forward to hearing about the case studies from Belgium, Spain, and France, and how they are addressing the challenges of financial protection. Seminars like this one, I think, will really enrich all of us. As we have seen, there is no single recipe on how to improve the financial protection of patients. Instead, we really need to look at what's out there, what people are doing. There is so much innovation, also at regional level and local level. So seminars such as this one really bring together a lot of people. I'm so pleased to see so many people actively interested in this. So my main message today is this is not the beginning. This is the start of a really important conversation, because I think now more than ever, we have to put patients in the center of health systems and provide everyone with the quality healthcare that they need and deserve. Thank you very much. I really look forward to listening to the rest of the webinar, and a big thank you to the WHO colleagues and to my colleagues, Clementine, for hosting this seminar on the EU's health policy platform. I wish you all a fruitful and inspiring debate. Thank you.
Thank you so much, Maya, for that very important call to action and reminder that the analysis that we've done is just the beginning. Now we hand over to the countries for a process of policy dialogue and hopefully action. Today's webinar is going to be in two parts. In the first part, we have John Silas, who's a senior health economist in the Barcelona office, and he is going to present to you the numbers on financial protection, importantly, the numbers on financial hardship across 40 countries in the region. And the numbers that he's going to present come from a regional analysis of financial protection that we published at the end of last year, using data in the years before the COVID pandemic, so that we can have a comparable baseline across countries. In the second half of the webinar, we're going to talk about the story behind the numbers. And for this, the second part of the webinar will be divided into three sections, and we will be focusing on country experience from Belgium and from France and from Spain. And we're really delighted to have with us today three experts from each of these countries, one expert from each country. We have Nicolas Bouquet from Belgium. He's an expert in health services research from the Belgian Center for Health System Knowledge. We have Damien Bricard from France. He's a senior research fellow at the Institute for Research and Information on Health Economics. And we have Rosa Urbanos Garrido, who is a professor of applied economics from the University Complutense in Madrid. So we will have that in the second half of the webinar. Throughout, the chat is open, so please put your questions in the chat. My two colleagues from Barcelona, Jorge Alejandro Garcia Ramirez, is going to be talking a little bit about UHC Watch, which is a new online platform that we've launched this year after John has talked about the numbers. And my other colleague from Barcelona, Lina Altayara, will be moderating the chat with Jorge very closely and letting us know if there are questions from all of you. So please be active in the chat. Okay, John, I'm going to hand over to you for the numbers.
Thank you, Sarah. Thanks, Sarah. So yes, so I'm going to talk about the main results on financial hardship from the regional report. Oops, there we go. So before I start, I want to talk very briefly about the methodology that we use. And as Maya mentioned at the beginning, this is a method that we developed in Barcelona about 10 years ago. I could talk probably for 2 hours about the method, so I've tried to consolidate this down to one slide to try and explain the intuition behind our method. So if you imagine that you take all of the households in a country and you were to line them up here from left to right, the poor to the rich, and you try and say, okay, well, how much money do we think that households can afford to spend on healthcare before experiencing financial hardship? Well, what we've done is we've decided households need to spend first on basic needs. They need to meet their basic food needs, their basic housing needs, their basic heating needs. And after they've met these basic needs, then whatever's left, some of that additional money can be used to pay for healthcare. And so the way that our method works is we create this threshold, this blue threshold here, which is the percent of a budget that a household can spend on out-of-pocket spending or experiencing financial hardship. And as you'll see, it starts very low for poor households on the left, which you can see from this very poor-looking house here, and it rises with wealth, so that a very wealthy household has a very high threshold. A very wealthy household has a very high threshold. And so what this means is that, of course, for a very poor household, once they've spent on housing, on food, on utilities, they have very little budget remaining to spend on anything. And so if they spend even 1%, 2%, 5% of their total budget on health, it's actually a lot of their disposable resources. Whereas for a very wealthy household, they could spend upwards 20, 30, 40, maybe even almost, as you can see, converging towards 40% of their total budget on health and still be able to meet their basic needs, still be fine. This is how we conceptualize catastrophic spending. We also, next slide, we also look at impoverishing spending. We look at how out-of-pocket spending influences the risk of experiencing impoverishment by looking at households who are, before they spend out of pocket, they are able to meet their basic food, housing, utilities needs. But after spending out of pocket, they no longer have enough budget to spend on these basic needs. So we say that these households have been pushed into poverty by out-of-pocket spending because their remaining budget after spending on basic needs, after spending out of pocket, is no longer sufficient to meet basic needs. We also talk about households that are further pushed into poverty. These are shown by the red line here. These are very poor households that are unable to meet their basic needs. They're already very poor, but they're still spending out of pocket on healthcare. And so we say that these households have been further impoverished by out-of-pocket spending. This is a very brief introduction to our methodology and how we think about financial hardship, but hopefully it helps to give a little bit of intuition as I show the results. So these are the results. We have results for 40 countries in the report. As Sarah mentioned, we look at data from the latest data we show for the main results is 2019, from before the pandemic. The reason being that very few countries had household budget surveys during the pandemic, and those that did sometimes have very strange results. It was very difficult to carry out these surveys during that time. And so what you see here, this is the risk of further impoverishment from out-of-pocket spending or impoverishment in orange, further impoverishment in red. And you can see that it varies across the WHO European region from very low, below 1% for a number of countries, or around 1% for a few countries, including Spain and Belgium, up towards around almost 12% in Ukraine. About, if we're looking just within the EU, the highest risk of impoverishment or further impoverishment due to out-of-pocket spending is in Bulgaria, where about 8% of households in the most recent data available experienced impoverishing spending. France, also quite low, a bit higher than Belgium and Spain, but still about 1.5% of households experienced impoverishing out-of-pocket spending. We look at catastrophic spending. This is oftentimes the main indicator that we focus our attention on. This also encompasses impoverishing spending. So all households that are impoverished or further impoverished are also catastrophic spenders. And what we see here is that this ranges from around 2% or lower in a number of countries, around 2% in Spain and France, around 4% in Belgium, and it ranges from that up to around 20% in Armenia and Bulgaria on the higher end within the European region. Now, as I showed with that first slide that had the effective threshold that's used to determine whether or not a household experiences catastrophic spending, the threshold is much lower for poor households than it is for rich households. I think this makes intuitive sense. Poor households experience financial hardship when spending less. It's much easier for them to experience financial hardship than a rich household. But I wanted to point this out because, of course, this leads to the result that we find in all countries higher risk of catastrophic spending among the poorest 20% of the population compared to the general population, the rest of households. So here in this figure, we have in light blue, this is the catastrophic incidence for all households, same as the figure I showed below with a different y-axis. And in dark blue, this is the risk of catastrophic spending amongst the poorest quintile. And you see for all countries, the poor have a higher risk of catastrophic spending, very high in some countries, if you look at Ukraine, Bulgaria, but still high even in countries like Spain, France, and Belgium that have relatively low levels of catastrophic spending. So just to put these results in a bit of context, we oftentimes show this figure, which shows out-of-pocket spending as a share of total health spending or current health spending, which is on the horizontal axis. So this is how much a country relies on out-of-pocket spending to finance healthcare. On the vertical axis is the catastrophic spending numbers. And what you see here is that, generally speaking, countries that rely more on out-of-pocket spending to pay for healthcare have higher catastrophic spending incidence. And you can see this very clearly. We have this diagonal line of best fit to sort of make this easier to see. But I think it's quite obvious by looking at this figure that you can see very clearly that there is this relationship that countries that rely more on out-of-pocket spending have higher catastrophic incidence. I do want to point out, of course, that there are countries that have similar reliance on out-of-pocket spending. So we have Spain circled here. Italy is very similar. Romania is very similar in terms of their overall reliance on out-of-pocket spending. But they have very different risks of catastrophic spending. And this is really the focus of this webinar, is understanding, and the focus of the regional report and a lot of our work is understanding what are the policies, what are the reasons that a country can have much higher or much lower catastrophic spending despite very similar risk of, very similar reliance on out-of-pocket spending to pay for healthcare. So what are households spending on? So here we have, this is sorted from left to right. Again, it's the same figure as the same order of countries as before, where we have the countries on the left are the countries that have very low catastrophic spending, so very good financial protection, and the countries to the right have very poor financial protection. And what we're looking at here is what are those households spending on? So in red, we have medicines. I know it could be a bit blurry for some people. So in orange, we have medical products. In blue is dental care. Yellow is outpatient care. green is inpatient care, and purple is diagnostic tests. And what we see is that the countries that have much higher catastrophic spending incidence, most of that spending in countries is due to medicines. We look at countries that have very low catastrophic spending. The households that do experience catastrophic spending are much more likely to be spending on things like dental care, as you can see in blue, especially in some countries, on diagnostic tests, on medical products. If we look specifically at the poorest quintile, the poorest 20% of households are spending, most of their spending is on medicine, the ones that experience catastrophic spending. So this bottom figure shows just those poorest 20% of households, and we see that it's much more driven by medicines. Even though for all households, medicines are the main driver, medicines are even more of the main driver in the poorest quintile. And we can see for countries like Belgium, France, and Spain that perform much better, medicines are still an important driver, but there's also other factors such as medical products and dental care, which are important drivers. And we'll hear a lot about that in a bit. Of course, I focused these slides on the risk of financial hardship. Not all households that lack financial protection experience financial hardship. Some of them, as Maya talked about earlier, experience unmet needs, so they're unable to use services, or they're not able to use all the services that they need because of the cost of healthcare. And so we see, if we look at the data generally across countries, we see that while richer households are, poorer households rather, are much more likely to have their catastrophic spending driven by medicines. In richer households, it's much more likely to be dental care. And you can see here that these bars here show the average across 33 countries of how much of catastrophic spending amongst richer and poorer households is driven by dental care. And we can see that the rich, 25% on average of the spending amongst those that do experience catastrophic spending is on dental care, whereas it's less than half that amongst the poorest quintile. However, if we look at unmet need, we see the opposite result. We see that unmet need is much higher amongst poorer households. The incidence of unmet need is much higher for dental care amongst poorer households than it is for richer households. And so I think it's very important. The main message here is that you need to consider both of these at the same time if you really want to understand financial protection, both financial hardship and unmet need. So I'm going to stop there and hand over to my colleague, Jorge, who's going to talk about UHC Watch and show a video. So over to you, Jorge.
Thank you very much, John, and good morning to everyone. So I'm going to talk about UHC Watch, which is a new online platform to monitor financial protection in Europe and Central Asia. And why did we develop this platform? This is because the WHO Regional Office for Europe is committed to helping countries in Europe and Central Asia move towards universal health coverage, which is affordable access to healthcare, meaning everyone can access the healthcare they need without experiencing financial hardship. And to make progress, policymakers need easy access to up-to-date, country-specific and user-friendly information on how their countries perform and what policies support or undermine affordable access to healthcare for people. John has already talked about how WHO Barcelona Office measures financial hardship and unmet need, which are two components of financial protection. But we also use other types of evidence to monitor financial protection, such as coverage policy analysis, what's the current situation on population coverage, service coverage, user charges, and voluntary health insurance in a country. And we also monitor health spending. And with these four types of evidence, we produce country reports and comparative analysis of financial protection. Now you can find all this evidence in one single place, which is UHC Watch, this innovative open access platform online to fill this gap in information and knowledge exchange. This was developed by the WHO Barcelona Office for Health Systems Financing and co-funded by the European Union. And UHC Watch presents evidence and analysis for more than 40 countries in Europe and Central Asia. It has different features such as a dynamic and easy-to-use interface. It has country pages with country-specific policy analysis and recommendations. You can access also all publications on financial protection for countries in the region. And we have also developed the European Financial Protection Expert Network, where our current speakers today participate, who systematically analyze coverage policy and financial hardship in their countries. And we think that UHC Watch can help governments, policymakers, and advisors to foster informed decision-making to progress towards UHC in their countries, but can also help academics and international organizations by giving access to the best evidence on international comparative analysis and research. So this is the background of UHC Watch, and now we will show you the video summarizing what UHC Watch offers to everyone.
As we work towards universal health coverage, or UHC, we need to ensure that healthcare is accessible and affordable, so that everyone is protected from financial storms. Affordable access to healthcare is known as financial protection. It is not only critical for UHC, it is a sustainable development goal. Countries across Europe and Central Asia have made good progress towards UHC, but many people still experience gaps in coverage. This means they face barriers to access or have to pay out of pocket for healthcare, sometimes at the expense of other basic needs. In this way, out-of-pocket payments can push people into poverty. We need to find ways to reduce these payments, but we can't do that without the right information on where and why things are going wrong. We also need to know what to change to make things better. This is why WHO Europe has created UHC Watch, an online platform with data and analysis on unmet need, financial hardship, health spending, and coverage policy in countries across Europe and Central Asia. Designed for policymakers and advisors, academics, journalists, and civil society advocacy groups, UHC Watch makes it easy to find the evidence, resources, and good practice recommendations you need. You can visit the country profiles for a snapshot of who experiences unmet need and financial hardship, and the health services and policies that are responsible. You can use the indicator and policy explorers to get a better understanding of the current situation and to monitor trends over time. You can generate your own analysis, comparing indicators and policies across countries and exporting data and graphics. UHC Watch has the evidence and analysis we need to move us closer to universal health coverage. UHC Watch, tracking progress on affordable access to healthcare in Europe and Central Asia.
So please visit UHC Watch, see the link in the chat, we will type the link now, and explore the possibilities to compare countries, access the wealth of evidence and publications, indicators, coverage policy analysis. This is the one-stop place to go to access information on financial protection in Europe and Central Asia. Now over to Sarah to continue the discussion.
Thank you, Jorge. We move on to the second part of the webinar today, where we're really looking at country experience. Clementine, can you put the slides up, please? That's great, thank you. So John gave us a very clear overview of the numbers of people experiencing financial hardship in the 40 countries that we study across the European region. In this second half of the webinar, we are going to be exploring the story behind the numbers, looking at questions like these. Why can't people afford to pay for healthcare? And importantly, what can countries do about it? In our work on financial protection, to help us answer this question, to look at the story behind the numbers, we focus on coverage policy. This is the way in which health coverage is designed and implemented in a country. And we focus on coverage policy because it's a really key determinant, not just of the level of out-of-pocket payments in a country, but importantly of the distribution of out-of-pocket payments across different groups in the population. It's also an important determinant of household and health system resilience to shocks, economic shocks like the global financial crisis, or health shocks like COVID-19. We try and identify gaps in coverage, because where there are gaps in coverage, there are going to be out-of-pocket payments, and some of these out-of-pocket payments will lead to financial hardship and unmet need for some groups of people in the population. So in looking at coverage policy, we start off by trying to identify the share of the population that has access, that is entitled to publicly financed healthcare in each country. And we try and work out who the people are who lack entitlement to publicly financed health coverage. We then look at the publicly financed benefits package. And if the benefits package is narrow, if there are issues with quality or waiting times for healthcare, then there are going to be out-of-pocket payments and potentially financial hardship and unmet need. We also look at user charges or co-payments. These are payments that people make at the point of using health services. And we look at the application of co-payments for publicly financed healthcare in the countries in our study. And in some countries, we also look at the role that voluntary health insurance or private health insurance plays in filling or not filling these gaps in publicly financed coverage. So at country level, we try and identify the main gaps in coverage in each country, and all of this information is available on UHC Watch. In our analysis, we also look at the coverage policies in a particular country, but then we look at them across the region. We look at coverage policies in countries with stronger financial protection and coverage policies in countries with weaker financial protection. And based on this analysis, we've been able to identify 5 coverage policy choices that we encourage countries to avoid. This is because they really are likely to undermine equity and efficiency in health systems. They have a disproportionately negative effect on people with low incomes or chronic conditions, and we've heard a lot about how important it is to protect these groups who are at very high risk of financial hardship. They also tend to increase inefficiency in the use of healthcare. They weaken resilience to shocks. They slow a country's progress to universal health coverage. And actually, in most cases, better options are usually available. So things don't have to be done in this way. Progress is possible. In our work, we also look at the policies in countries with stronger financial protection, and we've identified a list of good practice for policymakers, and that's at the end of the regional report or the summary report. So in this part of the discussion, we're going to be focusing on 3 different questions. First, why do so many countries fail to cover the whole population? Second, how can countries mitigate the negative effects of co-payments or user charges for healthcare? And third, can governments afford financial protection? And in each of these 3 segments, John and I are going to start with a brief introduction to set the scene, and then we're going to have a panel discussion with our country experts. So the first question for discussion in this second part of our webinar: why do so many countries fail to cover the whole population? Don't most countries in Europe cover the whole population? Isn't this something that Europe prides itself on? You can see from this slide that shows you the share of the population that is reported to be covered by publicly financed healthcare, that is entitled to publicly financed healthcare. You can see from this country that there are some quite visible gaps in coverage. In the countries, I've divided the chart into 2 parts. In the countries on the left-hand side, these are countries like Spain and France that report covering over 99% of the population. In the countries on the right-hand side of the chart, these are countries that report covering less than 99% of the population. And you can see there are some countries here like Belgium that cover just below 99% of the population. That's covering a pretty good share of the population. But in some of these other countries on the right-hand side, there are really quite large gaps in population coverage. So what causes these gaps, these very visible gaps in population coverage? The answer to this is in the basis for entitlement. If you live in a European health system, a European country, there are 2 main ways in which you can be entitled to access publicly financed healthcare. The first is on the basis of residence. You're a permanent resident in a country and you are automatically entitled to publicly financed healthcare. You don't have to do anything. These are the countries that are marked in blue in this chart. In the other countries, the countries that are marked in red, you are entitled to publicly financed healthcare if you pay contributions to a social health insurance scheme, or if the government pays contributions on your behalf because you're a pensioner or a child, for example. So these are mandatory contributions, effectively taxes that you need to pay in order to be entitled to publicly financed healthcare. And you can see on the left of the chart, countries that report covering most of the population, there's a nice mix of these blue and red countries. But on the right-hand side of the chart, overwhelmingly, in these countries with very visible gaps in population coverage, the basis for entitlement is payment of social health insurance contributions. And what this means is that if you're living in a country where the basis for entitlement is residence, as a normal taxpayer, you pay your taxes, the government uses those taxes to finance the health system. If you don't pay your taxes, you still have access to healthcare. The tax agency may come after you, but you still have access to healthcare. In contrast, in the countries on the right-hand side of the chart, if you don't pay your contributions, if you don't pay your taxes, the punishment for not paying those taxes is denial of access to healthcare. You may have access to emergency care, but you don't have access to the full range of publicly financed benefits. So there's a clear difference between these two types of policy. Do these gaps in coverage matter? Well, yes. One of the reasons why there are visible gaps in coverage in the countries on the right is because often these countries have quite large informal sectors, and the tax systems in these countries might not be as effective as they should be. So the people most likely to lack social health insurance coverage in these countries tend to be self-employed people, people in precarious work, people in unstable jobs, often quite low-paid jobs. So it has an important impact on equity. It's also inefficient because instead of giving people access to the full range of publicly financed healthcare, people have to rely on emergency services. And we know that use of emergency services is much more expensive for the health system than using services in primary healthcare. It also weakens resilience because coverage policy should be counter-cyclical, working against the economy. But in an economic crisis, as people are losing jobs, as their incomes and their salaries may be falling, this is the time when they find it hard to pay their contributions, and if they don't pay, they lose their entitlement and their access to most health services. And finally, we can see from this slide that it also increases financial hardship. The white dots you see on the chart are the incidence of catastrophic health spending in each of these countries. And in the countries on the right, the median incidence of catastrophic spending at around 9% of households is 3 times higher than the median incidence in the countries that cover most of the population. So we could say from this that universal population coverage looks like a prerequisite for stronger financial protection. I think it's important to note, though, that it's not a guarantee of financial protection, because if you look at the countries on the left, the countries that report covering the whole population, you can see that some of these countries have a very high incidence of catastrophic spending. So just being covered is not enough to guarantee financial protection. This is where other coverage policies also come into play: the benefits package, user charges, and so on. So what can countries do about this visible gap in coverage? Well, if you are a country that has entitlement that's based on residence, stay that way. Don't change. A surprisingly large number of countries that have residence-based entitlement think about introducing a social health insurance scheme and about introducing this link between entitlement and payment of contributions. But we encourage countries not to do that, especially if your tax collection system is suboptimal. And then for countries that already have this link between entitlement and payment of social health insurance contributions, we advise 3 things. First of all, don't punish people who don't pay their social health insurance contributions by denying them access to healthcare. Second, you can go further. You can break this link altogether. You can change the basis for entitlement to residence. And thirdly, let the tax agency deal with non-payment of taxes. This is fundamentally an issue for the tax system. It's really not something that the health system should be struggling with. Okay, we're going to move to our panel discussion now, and we're going to look at some country experience in this area to show you that it really is possible for countries to break this link without necessarily changing a lot of other things in their health system. This is something that France did nearly 25 years ago now. So in 2000, France changed the basis for entitlement to its social health insurance scheme from employment and payment of contributions to residence. I'm going to turn to Damien, our Senior Research Fellow from EADES, to say, Damien, why did France make these changes in 2000? What was it that motivated the government to introduce this important reform?
Thank you, Sarah. I will tell you some word on the French reform. So before the reform in the 90s, 800,000 residents, so a bit more than 1% of the population, did not have coverage through social security because they could not be affiliated directly or as a dependent person. They only have personal coverage, and for 200,000 of them, they do not have coverage at all. So the reason for that is that historically, coverage was linked to employment status in France, with an affiliation to the parents or spouse for dependent in case of long-term unemployment, inactivity, for example, and this necessitates change or even loss of coverage occurring in case of job loss, for example. And you also need to justify a minimum of activity, which is a problem for people with low income or poor jobs or self-employed people. And beside that, there's also a system to protect the poorest, those who have no affiliation to the social security and also low income and difficulty to afford complementary health insurance. It was previously complex, managed at the department level and with numerous formalities and different income thresholds on the different departments. So from 2000, after a new law in 1999 called Couverture Maladie Universelle or Universal Health Coverage, France changed the basis for entitlement from unemployment and payment or contribution to legal residence. This is the end of a long process of generalization of coverage, and this process ended in 2016 with a new protection law, with a new law called Protection Universelle Maladie or Universal Health Protection, and it grants all legal residents an individual, automatic, and continuous right to health care without the need for administrative formality when you have a change in circumstances. So the requirement for coverage in France is stable and continuous residence in France, at least 6 months on the year, and the PUMA, so the universal health coverage, is a real improvement for people with low income, poor workers or self-employment. And there is also one other point which is important. It makes people more independent with a personal affiliation and not as a dependent for the teacher or population that need to be covered as this before. As Sarah said, there are also a challenge for this change, for this reform. One of the challenges is the fact that before the system was financed based on the contribution from active workers, and it's not sufficient alone in such a system. In fact, it was difficult at that time because we were in a period of political debate on the reduction of public deficit, but also there was also a political mandate, so it was the good period related to the issue of social exclusion and poverty, because as I say, it was only 1% of the population not covered or in difficulty to be covered, so it was an issue of social exclusion and poverty. And the problem was addressed by the introduction of new income sources, and it's called the general social contribution. It was introduced in the 1991. It was a broader basis, including active workers, pensioners, people on unemployment allowance, and income from gambling and gaming. And in the time, the share of income coming from these sources has grown and now replaces salary contribution. More recently, I have to say that there was also an increase of the funding coming from taxes, and it comes from a portion of the value-added tax allocated to the finance of the system. So it's it's a good story for France. I hope it will be inspiring for other countries.
Thank you, Damien. That was very interesting to hear about the French experience. And I think France, before the reform, you had gaps in population coverage, and methods or measures to address those gaps actually added to the complexity of the system. So in 2000, changing the basis for entitlement to residence really simplified, but also expanded population coverage. At the same time, as you've said, there were concerns about the financial sustainability of relying so heavily on employment to finance the health system. And I think one of the important accompanying steps that France took was to change, to broaden the revenue base away from purely employment to look at other types of income. And I think that helped put the French health system on a more sustainable footing. But at the same time, the French health system is still really, really rooted in social security. And I think this offers an important way forward for other countries in Europe with social health insurance schemes. But often we see that countries can be reluctant to follow the example of France. And this is where I want to turn to Nicolas, because Nicolas, Belgium has a social health insurance scheme, and you managed to cover quite a large share of the population, but still there's around 1% of the population that lacks access to social health insurance coverage. So I want to ask you, Damien, is this regarded as a problem for progress towards universal health coverage in Belgium? And if so, do you think that Belgium could follow the French example and change the basis for entitlement, or do you think that there are obstacles that might get in the way of making this change in Belgium?
Well, Sarah, as you said, in Belgium, we're still in the SHE logic, so in the entitlement logic. That means that anyone over 25 years old or under 25 and working must do two things to be covered. You need to register with a sickness fund and you need to pay contribution. It's mandatory to enroll, but as you said, about 1% of the population lacks coverage, and that has remained more or less stable over time. And I think there are three main reasons for this gap. So first, you have administrative complexity or negligence, depending on how you want to frame it. For example, when somebody starts working and was previously covered as a dependent, they must register as a title holder. And failing to do so leads to a temporary lapse in coverage. Another example is when moving abroad to work, you need to take administrative steps to either maintain or discontinue your Belgian health insurance. A second issue is a failure, of course, to pay contribution, and this mainly affects self-employed individuals with low or no income whose contributions are not collected automatically, because for most groups like salaried workers, pensioners, people on replacement income like unemployment benefits, social contributions are either collected automatically or they are exempted from paying. And third, you have some specific loopholes. We know, for example, of errors such as being mistakenly deleted from the population registry, and that results in a loss of social rights. And this is, of course, also an issue that would remain if entitlement is residence-based. But I doubt, to answer your question, I doubt that entitlement rules will be changed in the short term. So the gap in population coverage receives, in fact, little attention in the broader debate that we do have on affordable access to care. And next weekend, there's this triple election coming up in Belgium. So not only the European election that most of you will go through, but also national and regional elections. So it's a good time to gauge the political climate. And so while the gap in population coverage hasn't been specifically addressed, discussions, and then especially in the Dutch-speaking region, emphasize that everyone should contribute fairly to the welfare system before being granted social benefits, so opposing the idea of delinking entitlement from contributions. And additionally, I think that there's perhaps a lack of interest for such reforms. So from the perspective of the general public, most people are unaware of this issue because their contributions are collected automatically, making them oblivious to the potential risk of a lack of coverage. And from the perspective of the decision makers, there are already structures and projects, although mostly outside the public health system, to provide care to undocumented migrants, to homeless people, to the financially most vulnerable. And as far as I see it, the focus is more on embedding these initiatives structurally into the public health insurance rather than on changing entitlement rules. And finally, that's where I end. I think that's also important to understand that the Belgium SHE system is not just about financing, it's not just about entitlement through contribution, but it's also about the division of power. Social partners, such as the representatives of the employers, employees, the sickness funds, healthcare providers, they play a crucial role in the decision-making process. And so any reform that shifts away from the SHE logic remains therefore challenging. And policymakers need to be strategic in how and for which challenges they use their political capital. And I don't think the priority will be on the entitlement issue.
Thank you so much, Nicolas, for that very, very interesting summary of the reasons why it might be quite difficult for Belgium to consider making this change, and some very valid reasons, but also some reluctance for perhaps cultural reasons, or because this is the way things have been done, or not wanting to change the social security flavor of the health system. And I think this is an important factor, because this reluctance to change the basis for entitlement to residence is something that we've encountered in other countries as well. And I think there are two feelings, or two fears maybe at play here. One is that perhaps it's unfair if people who don't pay their contributions still have access to the same social health insurance benefits as people who do pay their contributions. In other words, there's a feeling that, if you don't pay, then you should be punished for it in some way. And I want to reflect a little bit on the experience of Greece in the financial crisis after 2008, where in Greece, if you're entitled in Greece, your entitlement depends on payment of contributions to the social health insurance scheme. And we know that in Greece, unemployment soared, and around 25% of the people who are long-term unemployed lost their entitlement to social health insurance contributions. At the same time, the Greek system is not purely financed through social health insurance contributions, but a significant amount of public money for the system that goes into the social health insurance scheme in Greece comes directly from the government budget. So it's a mixed system that's financed through the budget and through social health insurance contributions. And you have a situation where people are paying their taxes, income taxes or VAT, to the government budget, but they're not paying their social health insurance contributions. And their taxes are being used to finance social health insurance benefits, but because they're not paying their contributions, because it's administratively complex, or they simply cannot afford it, and the tax enforcement is just not there, these people are not accessing the same benefits, but they're subsidizing the benefits that other people access. So in a sense, that becomes very unfair. And I think that we're not suggesting that people shouldn't pay their contributions, or that they shouldn't face some penalty for not paying their contributions, but just that penalty shouldn't be denying people access to healthcare. There may be other penalties in the tax system and so on. And the other fear that we have encountered is where people think, well, if people don't have to pay their contributions and they still get access to social health insurance benefits, then where's the incentive for other people to pay their contributions? And won't people just overnight stop paying their social health insurance contributions? And here I just want to bring in the example of Czechia, where entitlement is based on payment of contributions. But if you don't pay your contributions, you are not denied access to healthcare. So the Czech health insurance system continues to cover you for as long as you don't pay your contributions. Of course, they will chase you for the contributions, but you will still have access to healthcare. So this is a kind of softer way, a softer approach to breaking or softening this link between entitlement and payment of contributions. I'm going to stop now, and I'm looking at Lean here to see if there are any questions in the chat. If we have time for a couple of questions for the speakers, the country panelists. Lean, over to you.
Thank you, Sarah. Yes, the chat has been very active, so we're very happy about that. But there's one question for Damien. So some people think that if a country decides to cover everyone, this would lead to a big growth in public spending on health over time. Did this happen in France? Over.
it's difficult to answer, but I think that when we look at the French situation, the reform in 2000, as I say, was I think at the end of the process of enlargement, and in fact, the fact to cover the last 1% not covered was not a big public expenditure, and we can also say that probably it simplifies a very complex system. So at the end, maybe we have a more efficient system, and maybe what is more costly, and I will talk for that after, is the way that we cover the population with the complementary health insurance, because at the same time the French, for the poor, create a complementary health insurance which was free for the poor, and which was a bigger cost, social cost, but it was in fact another aspect of the coverage. So not a big jump in public expenditure at that time.
Thank you, Damien.
And I think I have another argument because of the last debate on the history of France, is that in fact, as in Greece, as we start in the 90s to increase the share of financing coming from income and taxes, it was an argument to make the universal coverage.
Back to you, Sarah.
Thank you, Lynn, and thanks, Damien, for answering that question. So I think that it's very possible. Damien, the French experience has shown us that it's really possible for social health insurance schemes to break this link between entitlement and payment of contributions and still keep the flavor of a social security system. I think there are concerns about fairness and solidarity on one hand, and incentives about people paying contributions or not on the other, but often these concerns are not borne out in reality. And even where there are these concerns, these are really problems for the tax system. This is something that the tax system should be addressing, not really the health system. So far in this first bit of the discussion, we've talked about, we've been focusing on these very visible gaps in population coverage in countries with social health insurance schemes. And some of you who come from countries with residence-based entitlement have probably been relaxing and thinking this is not a problem that we have to deal with and feeling quite pleased with yourself. But there are also much less visible gaps in population coverage in any kind of health system, in systems based on entitlement, where entitlement is based on residence, and where entitlement is based on payment of contributions. And this is a gap for undocumented migrants. This gap is usually, it's not visible, partly because it's very, very small. Usually undocumented migrants are a very small share of the population in countries in Europe, but also because countries often report covering the whole population, even when they don't cover undocumented migrants, or only make very small small aspects of healthcare available to them, emergency care or whatever. I want to go to Rosa now, because Spain has a really interesting story of making a change to the basis for entitlement during and after the global financial crisis, changing the basis for entitlement from residence to payment of social security contributions and the reversal of this change. So, Rosa, what motivated Spain to make these changes in 2012?
Thank you, Sarah. Well, I first wanted to say that the change for entitlement from residence to social contributions wasn't followed by a change in the financing of healthcare system, because the financial source is tax, general taxes, not social contributions. Well, the main reason to reform the basis for entitlement was, of course, public finance in Spain, because the reform was approved at 2012, and at that time there was a high public deficit in Spain, rounding around 9%. But there were also some concerns about migration and the use of healthcare by migrants. Although, as I say, the main impulse for the reform was the pressure from the European Union to cut the deficit, to cut health expenses, and to do it quickly. There's a funny story because the reform was so rushed that the law unintentionally excluded all the contributors' dependents, wives or husbands and children. And as a consequence, many Spanish citizens stopped having right to healthcare overnight. So 3 weeks after the approval of the first text, there was a massive error correction, and these people were finally included. So at the end, the reform mainly excluded undocumented migrants, and the consequence was an increase, for example, in the incidence of infectious diseases such as tuberculosis, syphilis, HIV, and even an increase in mortality. The exclusion of undocumented migrants was highly controversial in Spain, among other things because it was claimed to be ineffective, because most migrants are healthy and young, so they don't use healthcare a lot. And in fact, this exclusion may have cost externalities, so it may be against efficiency as well. And many regions refused to implement the reform. So it was a very political issue, a high important issue at that time. When the government changed in 2018, the reform was immediately reversed. There was a clear political priority to include again undocumented migrants in healthcare coverage. However, some access administrative barriers still persisted after the reversal of the reform. For instance, undocumented migrants who have been in Spain for less than 90 days need a report from social services to healthcare. So there is some barriers to access. But now, at this moment, a new law is being discussed, especially in the Spanish Parliament, with the aim to remove all these barriers. So we are advancing in this issue.
Thank you so much, Rosa. And I should say, I was going to say at the beginning, one of the reasons we chose this selection of these 3 countries, Belgium, France, and Spain, is because they generally have quite good financial protection, but all of them have gaps in coverage. But one of the key characteristics of the 3 countries is that the countries really do recognise the gaps they have, and the governments have been active in taking steps to close these gaps. Your story, Rosa, about undocumented migrants in Spain and the very explicit change in the law that aimed to shut them out, I think it's a really clear illustration of the political choices involved here. Whether to cover undocumented migrants, to what extent they should be seen as part of the health system and entitled to the same benefits as other residents, really is a question of political choice. And it's a choice that Spain, which is not as rich as France and Belgium, has made. And Spain, some of you may not know, but Spain probably has one of the most generous entitlements for undocumented migrants in Europe. Most countries only give undocumented migrants entitlement to emergency services and maybe some treatment of communicable diseases and so on. And this is something that we've been monitoring through the UHC Watch platform, where you can see what the entitlements are for undocumented migrants, but also for asylum seekers and refugees. And we're trying to map this systematically across countries. So Spain showing the way forward in this particular area, and also showing the role of political choice in granting entitlement to different groups of people. So on that very positive note, I'm going to bring this discussion of population coverage to a close. And I was going to hand over to Tamas to talk about co-payments, but Tamas unfortunately was not able to join us today because he's not well. So you're going to have to bear with me for a little bit longer before I hand over to John for the 3rd session. So the second question for discussion today is, how can countries mitigate the negative effects of co-payments? I just want to start this this very short presentation by reminding you of something that John showed you already, and that's that financial hardship and catastrophic health spending is really heavily driven by out-of-pocket payments for medicines. And you see this in countries with weak financial protection. It's medicines, the bit of the chart that is in red, that is really driving financial hardship in those countries on the top panel towards the right. And when we focus on the poorest fifth of the population, which is the bottom panel, you can see that medicines are a much stronger driver for people with low incomes than they are for people on average in the population. So medicines are really, really a key reason for financial hardship across countries in our study. And there are various reasons for that. If we're thinking about trying to improve financial protection, trying to increase affordable access to medicines, to healthcare in general, medicines have to be a huge part of that story. And I just want to very quickly go over 3 steps for achieving that. The first one is ensuring that medicines are part of the benefits package. And for many of the countries in our study are EU countries, relatively high-income countries. But this is not a question. Medicines are always part of the benefits package. But there are some countries in the region where coverage of medicines feels like an afterthought. The benefits package for medicines is much, much smaller. And I just want to very quickly illustrate with this case study from Georgia. So Georgia had a very, very important reform in 2012, 2013. They didn't cover very many people in the population before that. So part of the reform was to massively extend population coverage to over 95% of the going from about 30% of the population to over 95% of the population. They also put a lot of public money into the system to pay for this enormous population coverage expansion. But that money was really heavily focused on inpatient care. So you can see that in 2018 and 2011 in Georgia, before the reform, the catastrophic incidence was quite high. But once the reform happened, the catastrophic incidence actually went up. Even though the out-of-pocket payment share came down because public spending was increasing, the catastrophic incidence went up. And one reason for that was because the government was very, very keen to protect people from what they considered to be very high costs relating to inpatient care. And so most of this extra spending on health went into the inpatient care budget. And they paid less attention to outpatient medicines. So outpatient medicines were not so well covered. And if they were covered, there were very heavy co-payments for those medicines. As a result, unmet need for inpatient care really fell very rapidly, and the costs to people out of pocket of paying for inpatient care fell very rapidly, and that's what the second chart here shows you. But spending on medicines, which have been a second priority for the government, increased, and financial hardship increased, driven by spending on medicines. So medicines really have to be part of the benefits package. But as I said, that's not so much of an issue for many of the higher income countries in the EU. The second step is to focus on protecting households and not just protecting the public purse. And this is where the issue of co-payments really comes in. So the chart on this slide here shows you for EU countries, the percentage of those countries applying co-payments. And you can see that most countries apply co-payments to some services. But countries also try and protect people from co-payments for things like inpatient care, GP visits and specialist visits, and emergency care, and so on. When it comes to outpatient medicines, for some reason, all countries in the EU, with some 1 or 2 exceptions, impose co-payments for outpatient medicines. So there's something about outpatient medicines that really makes countries think, oh, this is something that we need to pay, we need to make people pay for at the point of use. The other interesting thing here is that we can distinguish between fixed co-payments where people pay, say, €1 or €5. The co-payment is fixed in advance, and percentage co-payments where you pay a percentage of the price of a medicine. And for outpatient medicines, the type of co-payment that is used is overwhelmingly this percentage co-payment. So there are 2 things here. One is that countries really feel that outpatient medicine should have user charges applied to them. And often this might be because countries think that there's waste in the system. If we don't make people pay, they won't be careful about using medicines, and so on. But there's a huge body of quite consistent evidence that shows us very clearly that user charges or co-payments are not a good policy instrument for steering people to use or not use some types of healthcare. So even if you have problems with inappropriate use of healthcare in your health system, user charges are not a good policy instrument for trying to address that particular problem. And this tends to be because a lot of the problems around inappropriate use of healthcare are actually driven by what happens through providers. It's providers who are really driving some of these issues. So if you have a problem with inappropriate use of healthcare, the solution is really to focus on what providers are doing and not try and use user charges to steer patients. The percentage copayment, I want to come back to this because it's really interesting that so many countries apply percentage copayments to medicines rather than fixed copayments. And one reason for this is because it can be quite good for the budget of the PAPS or the Health Insurance Agency or the National Health Service, because the purchaser will know how much they have to pay and how much the patient has to pay. But it can be perceived as being very unfair because it shifts the burden to patients. And if you happen to have a condition that requires more expensive medicine, then you will have to pay more than somebody who is lucky enough to have a condition that has cheaper medicine. So one of the messages here is choose your disease carefully. Make sure that you have a disease that has quite cheap treatment, and then you won't have to pay so much out of pocket. The other type of user charge that is really widely applied to medicines, in addition to percentage copayments, is reference pricing, where the health insurance fund sets a reference price, but if in the pharmacy the medicine costs more than that reference price, the retail price is higher, then the user has to pay the difference between these two prices. And again, this is something that is done often to protect the budget of the health insurance fund, but it can, like percentage copayments, it can be very untransparent. So people may not know in advance how much they have to pay for healthcare. And this causes lack of financial certainty and so on. And the premise is that patients are the ones in the driving seat here. They're the ones who have good information about prices. They know exactly how much things cost. But I think all of us know from our experience as patients that often this is not the case. So these are two types of user charge that are very widely applied to medicines and have a lot of issues with them. So in our analysis, we do not conclude that countries necessarily have to abolish all copayments. What we do conclude is that how you design your copayments really matters. This chart shows you the incidence of catastrophic health spending that John has showed us before across the different countries in the study. And we've divided countries up based on the design of copayments for outpatient medicines. And you can see that in the countries on the right of the chart, there's very, very heavy use of percentage copayments. So this is where you pay a price of the medicine as a patient. And that there are protection mechanisms in place to protect people from copayments, but often these copayment mechanisms are quite limited. So exemptions from copayment don't necessarily apply to people with low incomes, for example, and often there's no cap on copayments in these countries. In contrast, on the countries on the left of the screen, the countries with generally a lower incidence of catastrophic health spending, these countries have copayments for outpatient medicines, but they also have multiple protection mechanisms in place. So they have exemptions for people based on income. So low income people may be exempt from having to pay any copayments, or they have caps. And again, these caps are linked to income so that they're more protective for people with low incomes, but still protecting everybody who pays copayments. Some of these countries, a small handful, use low fixed copayments instead of percentage copayments. So people know in advance exactly how much they have to pay when they get a prescription in the pharmacy. And then there's a small group of countries in yellow where countries use voluntary or private health insurance to cover copayments. And that's something that we'll be focusing on a bit more in the third bit of this discussion. So what this slide is really telling you is that the way in which you design your copayments can have a big impact potentially on financial protection. So the third step in this three-step process is to really focus your protection on the people who are most in need of protection. And John showed us very clearly that households in the poorest fifth of the population, households with lower incomes, are the ones that are at the highest risk of financial hardship, but also people with chronic conditions. And if you have one chronic condition, you're more likely to have more than one chronic condition and have regular need to take medicines. And this, even if the medicines, the individual amounts that you pay are small in absolute terms, they can accumulate and become a burden, or they may be large in relation to your income. So one of the clear messages from our work is that it is important to exempt people with low incomes and chronic conditions from user charges, and to have a cap on co-payments, because caps can protect everybody. This is just a summary of the coverage policy choices that we encourage countries to avoid. One of them is applying user charges without having effective protection mechanisms in place. And here we have a good practice checklist focusing on the design of co-payments for medicines, with some key messages here. Okay, I'm going to stop there and hand over to John, who's very kindly agreed to help me lead the discussion. So John, over to you for the discussion on co-payments with our country experts.
Thanks, Sarah. And I think you made some really important points about how most countries do use co-payments. And we saw in the earlier slide that I showed with the scatter plot, where I showed the reliance on out-of-pocket spending on the horizontal axis and catastrophic spending on the vertical axis, how countries that have very similar overall reliance on out-of-pocket payments can have very different risks of catastrophic spending. And this has a lot to do with the design of co-payment policies. It has a lot to do with who ultimately ends up paying out-of-pocket, ends up paying co-payments, how much they're paying, whether there are protective mechanisms in place. And so what we want to do in this second session is hear from Spain, Belgium, and France about how they manage to use user charges, use co-payments, but still perform very well when it comes to catastrophic spending. So I want to start, Rosa, with you. So we've heard a little bit earlier that co-payments in Spain are really only for medicines, but we look across Europe, medicines are the driver of catastrophic spending, and yet somehow Spain manages to have very low catastrophic spending. Medicines are not a major driver, although they are still an important driver of catastrophic spending. So how does it work? How do the protective mechanisms work in Spain, where you're able to have only co-payments for medicines, but still very low catastrophic spending?
Thank you, Jan. Well, we have several protection mechanisms. For instance, for pensioners who previously, before the reform established in 2012, they were exempt from user charges, but they had to pay from that moment on. But the change was followed by a lower percentage of payment for most pensioners, and also was followed by an income-based cap. So the maximum amount that a pensioner must pay is rounding €8 per month, and the maximum 61, depending on income. And well, for no pensioners, there's no cap. And the result has been a shift in catastrophic spending from older to younger people in the crisis. For instance, the proportion of households with catastrophic spending headed by a retired people or a pensioner was reduced by half from 2006 to 2019, and the proportion of households with catastrophic spending headed by an unemployed doubled. So I think this highlights the importance of having caps for co-payments. Another element that contributes to financial protection is that a large list of medicines which are prescribed for chronic conditions has a reduced percentage of co-payment. So there's an additional mechanism of protection, because the price for these medicines is capped at around €4. And this is a huge list of drugs. And in Spain, in the last couple of years, exemptions from user charges have been widened on the basis of income, health status, and other criteria. So now the exemption applies to, for instance, those who benefit from the minimum vital income, low-income pensioners, beneficiaries of non-contributory subsidies, unemployed who no longer receive public benefits, and so on. So the list of those who are exempt from user charges is quite large now. And also, I imagine that it's similar in other countries, but the Spaniards have traditionally shown a strong opposition to co-payments. And in 2012, with the reform, the law opened the door to new co-payments for some benefits, for instance, for non-urgent health transportation and some other benefits, but the government didn't dare to implement them because the opposition was huge. And now at this moment, the law that I mentioned before, which is being discussed in the Spanish Parliament, is trying to avoid the introduction of new co-payments. So the priority for the Spanish government is to keep co-payments at minimum.
Great, thanks, Rosa. I mean, it sounds, on the plus side, when you mentioned the use of caps for pensioners, it's good evidence that caps, income-related caps work, that they are able to provide protection. But as you said, it's problematic, of course, that it's not applied to other vulnerable households, unemployed households. And I think also you're mentioning of the wide use of exemptions. I mean, I know it's not part of the session, but the UK, for example, in England, I remember that despite there being co-payments, I think the £9 something co-payments for all prescriptions, but something like 90% of medicines were dispensed without a co-payment. So because of the wide use of exemptions. So I think these examples of applying income-based co-payments, income-based caps, lots of exemptions for vulnerable groups who are high users of care, and also keeping the overall fixed cost not below a certain threshold, which I think you said was €4. These are effective mechanisms to try and make sure that people, despite the use of co-payments, that people don't experience catastrophic spending. I want to turn, Nicholas, to you, to Belgium. So Belgium has widespread use of co-payments and a lot of mechanisms. Can you try and explain a bit the use of co-payments, but also what mechanisms are in place to try and protect people and where you see there are gaps?
Yeah, so in Belgium, John, we have user charges that apply to almost every service, so including GP care, emergency care, prescribed medication. And there are no general exemptions for low-income households or chronic care users. And although these user charges are often small, like for example €4 for a GP consultation, they can add up and become a barrier, as Sarah already said. And another barrier for outpatient care is that the default rule is that patients have to pay the full price up front and are reimbursed later by their sickness funds. But on a positive note, most percentage co-payments have been replaced by fixed co-payments. So that's a good evolution, although some percentage co-payments remain, for example, for prescribed medication. On the other hand, so we have these widespread user charges, but we also have several financial protection mechanisms that aim to limit the negative impact of these charges for low-income households or for chronic care users. And these mechanisms have also been reinforced gradually over time. So first, a major one is that low-income households can be eligible for reduced co-payments, and about 20% of the population is entitled. For example, they pay only €1 for a GP consultation instead of €4. They also benefit from what we call the mandatory third-party payment system for GP care, meaning that they only have to pay the out-of-pocket price and not the full price. And recently, since October 2023, eligible children are also exempt from co-payments for GP care and for outpatient specialist care. But a major issue with this protection mechanism is, however, that low-income households without social allowance, they do not benefit automatically. They need to apply for it. And so this administrative hurdle that leads to important non-take-up issues, leaving about 1 in 3 households in poverty without this protection. A second protection mechanism is the annual cap on co-payments for each household. So major strength here is that it is a global cap on all co-payments and that it is differentiated by income. So ranging from the lowest cap is about €250, the highest is about €2,050. And this cap can even further reduce if one of the household members is a chronic care user. The lowest cap was introduced recently in 2022, and in 2023, all caps were frozen as a response to the cost of living crisis. These caps are calculated and applied automatically, but households are not informed in advance about the applicable cap. And so these two protection mechanisms, they are crucial in reducing co-payments, but they are more complex than a simple exemption. And additional to the non-take-up issues and the limited information, they can create some unfairness and intransparency in the system. But probably the biggest issue that I have not yet mentioned is balance billing. So it's a major concern for affordable care in Belgium. Balance billing adds a new layer of complexity to the system, and it isn't covered by any of the main protection mechanisms, so undermining, in fact, their effectiveness.
Thanks, Nicholas. It's really interesting what you mentioned with the second point about that people don't automatically qualify for the caps. So how do people know if they qualify? What do they have to do?
For the income-based cap, so every household qualifies, but it is calculated automatically by the sickness funds based on the taxable income of 2 years earlier. So once you reach a threshold of 250, the sickness fund will calculate based on your income what your applicable cap is. They won't inform you about it, but once you cross your threshold, your cap, then they will reimburse your co-payments.
Okay, thank you. Maybe I'll move to Damien. So Damien, can you tell us, so in France, there's widespread use of co-payments, statutory co-payments, but actually very low out-of-pocket spending overall. And of course, we've seen very low catastrophic spending. And I saw some interest in the chat with questions about voluntary health insurance. So maybe you could tell us a little bit about how it works in France and how people are protected from co-payments.
Yeah, thank you, John. So as in Belgium, yes, you have generalized other charges for all types of care. And the French system rely on exemptions, but also on the role of complementary health insurance. So it's not clearly a voluntary health insurance because it's mandatory for some people, and it's complementary because it's for their role for all type of care. So you have a percentage co-payment of around 30 or 40% for quasi all of type of care, which are covered by the complementary health insurance for percentage co-payment. And you have also fixed co-payment, for example, for emergency visit or for hospital stay. They are also covered by complementary health insurance. But also you have fixed co-payments that are not covered by complementary health insurance, and they are low level, but it's still €1 per package of medicine, for example, or €2 now for each GP consultation. So in the system, there are no overall cap on co-payment. There are no such system as in Belgium, except 2 annual cap at €60 for the 2 set of service with fixed co-payment. And in addition to co-payment, we have also worry about balance billing that are permitted for some doctors and dentists in outpatient care, and also large balance billing for medical products such as crown, bridges, and denture. And this balance billing can be partially covered by complementary health insurance. So, as I said, for all these co-payments, there are exemptions. This is for low-income people with free or subsidized health insurance. So they are exempt for fixed co-payment, and they are covered for percentage co-payment as all other complementary health insurance. And they also are exempt, or professionals cannot ask for balance billing for doctor visit. And another major exemption in the French system is the one for people with chronic condition. So there are an extensive list of chronic conditions that are covered, and those people are exempt from percentage co-payment, and it covers almost 18% of the population having a chronic condition. So it's a huge exemption based on income on the one hand and chronic condition and the other one, with the huge use of voluntary or
Voluntary insurance.
complementary health insurance.
Great, thank you, Damien. I know we're running behind on time, so I'm going to go to Lynn and see if we have any questions in the chat for the panel.
Thank you, John. Yes, I have one question for Nicholas. So it's been discussed that when protection mechanisms are made automatic, that that people are more likely to take them up. But in the case of Belgium, what are the obstacles of granting automatic entitlement to these reduced copayments for the people who are eligible? Why not make it automatic? Thank you.
Well, they're trying to make it automatic, but it is not that simple. So to assess eligibility for reduced copayments, you need information, you need timely information on income and on household composition. And not all the data that are needed to check eligibility are currently available for the administration. So either you need to change the eligibility conditions or you need to collect more data. And that's a trade-off that has to be made because these eligibility conditions, of course, they are defined just simply to identify the low-income households. So you need to find a balance between identifying these low-income households using as much information as possible, or simplifying the system and using only information that you have available so you can automate the process.
But Nicholas, so, sorry, just as a follow-up. So these data, they exist though, right? It's just that the health insurance fund doesn't have the data.
No, not all data exist. So for example, they're trying really to compose the families, like people living together, but not only like legal partnerships, but simply two people who are forming a family. But this is not registered nowhere in the population registry, only if it's a legal partnership. So that is information that the sickness funds have to collect from the people applying themselves.
Okay, great. Thank you for clarifying. I mean, I think that's a really interesting takeaway that when we look at this session overall, that clearly there are protective mechanisms that are possible to protect households from copayments, even though all countries are going to, or most countries are going to use copayments. But what I think maybe doesn't make sense is creating these administrative hurdles, making it difficult for people to obtain benefits that they are eligible for or should be eligible for. It would make sense to have a more automatic system. You see this in countries like Estonia, countries like Austria, where people are much clearer that people are they're automatically informed what they're eligible for, what protections are available. I'm going to move ahead because we are behind schedule. So much like Sarah closed the last session and then opened it herself, I'm going to close this one. Thank you, panelists, and then open the next one myself. Welcome back to topic 3. So we're going to close with talking about, can countries afford to pay for, once I can have control over the slide, there we go. Can governments afford financial protection? So I wanted to show this first slide. So this is a different scatter plot than the one I showed before. If you remember an hour and a half ago, who does? We have catastrophic spending incidence on the vertical axis and public spending as a share of GDP, public spending on health as a share of GDP on the horizontal axis. And our 3 countries are circled, although Spain is circled a little lower than it really is. It's, if you can see, there's a tiny green dot above Spain, which is the real Spain catastrophic spending dot. So what's the takeaway of this figure? So I think the important message here is that countries that spend more from public funds generally have less financial hardship. I don't think this is going to come as a major surprise that the countries that have more money to spend and that spend more of their budgets perform better in general. They have more funding equals lower catastrophic spending. I wanted to push the down arrow. That's not how this works. There we go. Countries that spend similar amounts from public funds have very different catastrophic spending incidents. I talked about this earlier with the same countries, Italy and Spain, 2 countries that have very similar GDP per capita, very similar public spending on health, very similar reliance on out-of-pocket spending, but very different incidence of catastrophic health spending. So we see Spain very low, coming in at around 2% of households experiencing catastrophic spending, and Italy is close to 10% and fairly consistent over time. why? So I think the thing to keep in mind here, and I think something that probably has been sort of under the surface as we've been talking here, is there's always trade-offs, right? Countries make choices about who they cover. They make choices about what services they cover. They, as we talked in the last session, about how much of the cost is covered, as well as for whom. Does everybody pay co-payments? And all of these choices have consequences for affordable access. So again, it's really trying to exploit this idea that you can have countries that have very similar reliance on out-of-pocket spending to pay for healthcare, very similar reliance on public funds from GDP to pay for health, but very different catastrophic spending. And of course, this, as I think we talked briefly in the chat, this also reflects other contextual factors, but the policy choices that you make in the health system are going to have implications for the risk of catastrophic spending, the risk of unmet needs, and your ability to affordably access care. And just to illustrate this, I come back to unmet need data, which Maya opened with, and this is data from EU SILC, which we also include in the regional report. On the left is unmet needs for healthcare due to cost, waiting time, and I don't remember the third reason, mostly cost and waiting time. And you can see that it's these countries again are sorted from left to right, from the households, the countries that have the lowest rates of catastrophic spending on the left to the highest rates of catastrophic spending on the right. I would say for healthcare, you generally see, although with lots of variability, that the countries that perform worse for catastrophic spending also perform worse for unmet need. Again, not always the case, especially when you look, for example, at Belgium. Belgium has fairly high unmet needs for healthcare, relative at least to the other two countries, Spain and France. But when we look on the other side of this figure, we look at unmet need for dental care, and we see a very different picture, that oftentimes countries seem to cover healthcare, but then and cover a large share of the cost for a large group of people and a lot of benefits. But when it comes to dental care, it's oftentimes missing from the benefits package. And we see this particularly when we look at unmet need for poorer households, and we see much higher rates of unmet need, especially compared to richer households. So the poorest quintile being in red, the richest being in green. And in most of these countries, until we get really all the way to the right of the figure, the rich are still able to access dental care. They don't really report so many unmet needs. Of course, it changes a bit as you get further along, but it's really the poor who are excluded when countries decide what to prioritize. Again, this came up a little bit in the previous session. Some countries may think that they can use private health insurance to fill gaps. So in the case of Spain and Belgium, private health insurance is used primarily to give faster access to care where there's long waiting times. Whereas in France, as we heard a bit, there's complementary voluntary health insurance to cover user charges. Whether this is able to fill gaps, and I think we should probably say up front that voluntary health insurance, private health insurance, is not a very good way to fill financing gaps. It's not a very good way to try and put plasters over the parts of the coverage system of your health system where you haven't put enough resources. But we'll talk about that in the rest of the session. So we're going to get to the question. We only have 15 minutes left for the whole thing, so we'll probably try to be a bit quick. So the big question here is, how do Spain, France, and Belgium afford good financial protection? I think we've seen now, looking at enough of these slides with Spain, France, and Belgium, that they're always the countries to the left of the figure, right? They're always the good or pretty good performers in the case of Belgium. So what do they prioritize? How do they ensure good financial protection? So I'll bring back our panel. I don't know where you guys are, still there. And I'll go to Rosa first. So Rosa, can you tell us, we've talked a little bit about the fact that Spain does not use co-payments for anything besides medicines. We talked about the protective mechanisms that are in place, but what is this at the expense of? Where are the gaps as a result?
Yeah, well, that's right. We have a very generous benefit package and low co-payments, but there is a trade-off, and the trade-off is that some important things are out from this generous package, such as more dental care. In fact, only extractions are publicly financed for adults. Glasses and contact lenses are out of public coverage, hearing aids. So there's a trade-off, of course. And another price to pay is waiting times. Waiting times have traditionally been an important issue in Spain, particularly in the latest years after the effects caused by the Great Recession and by the pandemic of COVID-19. And the result of this increasing waiting times has been a significant increase as well in the purchase of voluntary health insurance of VHI, which obviously is not homogeneously distributed among families. There is an unequal take-up of VHI. In Spain, the proportion of households in the richest quintile with private insurance triples that for the poorest quintile. And importantly, in the Spanish case, at least, VHI doesn't reduce out-of-pocket payments because the private insurance in Spain is basically supplementary, usually doesn't include reimbursement for medicines, and also complementary insurance to cover dental care is not very widespread. So the protection guaranteed by the private health insurance is not such. But to my view, there may be a higher problem related to VHI, because I think that if an important part of the population purchases voluntary health insurance, it may put at risk what is called the social sustainability of the health system. That is, if the middle classes stop using public health care and jump into private sector through the VHI, they may delegitimize tax collection to pay for services they do not use. So the final scenario may be a poor NHS providing poor care for poor people. And I think this is a real risk, at least in Spain. However, the Spanish government is now trying to cover the gaps. Of course, big efforts are being made to diminish waiting lists, but the benefits package is also being widened. So efforts are being done to cover vulnerable population groups relating dental care and eye care, glasses and contact lenses.
Thank you. I think that's a really good point that you made about the VHI, the reliance on VHI to fill these gaps, despite there being these long waiting times, really does risk the development of a two-tiered system and ultimately erodes the solidarity for the public system. And like you said, a poorly funded system for the poor, I think is a really good way to put it. I want to go to Damien. So you talked in the last session about how VHI is really key to ensuring financial protection because it covers co-payments. Does it work well? And what are the consequences of relying on voluntary health insurance? Is this a good way forward?
Yes, it's clear that France rely a lot on complementary health insurance for the financial protection, and because it's covering co-payment and balance billing. And now, as John showed, it covers 96% of the population and accounts for 13% of current spending on health. So it's very high level of take-up of CHI in France reflects effort and a long story of effort of the government to cover the population because of the co-payment. So the first one, as mentioned before, is for poor people, and it was improved also in 2019 by a new approach, a simplified approach. And there are also efforts for employees, because now it's mandatory for employers to propose CHI for their employees, and it's subsidized. And now it will be extended for public employees. So it's a long way of effort, but still 4% of the population is not covered. because it needs a very low income to be eligible for the one which is free or subsidized, and because the last test reform concerned employees, which is not the case, which not covered short-term contract, inactive individual or pensioners. So the consequences of that is that you have disparity in coverage and quality, and relying on CHI is also potentially a regressive way of financing health because it's not linked to income. And those who are not covered by employers are also more expensive individual contracts, and it concerns also the pensioners. So when you the last reform increased this co-payment and the rely on the CHI, so one of the issues is that for those who are poor but not not covered by the free, it's more and more a burden for paying the premium for CHI. So it's very difficult. And in addition, there are also costs associated with the subsidies, but also tax incentive for employers. And there are also significant administrative and transaction costs for insured individual and healthcare professional due to the, in fact, dual reimbursement process. You have to be reimbursed first for the social security part and then for the complementary health insurance part. So it's maybe it's costly and unequal in terms of coverage. Yeah.
No, I was just going to say it sounds complicated, and as you said, there are lots of people who slip through the cracks as well. I just want to flag, someone mentioned in the chat a question about how, if not VHI, then what? How do you fill these gaps? And it brings to mind a nice example from Slovenia. Slovenia, much like France, historically has had voluntary health insurance, complementary health insurance that covered statutory co-payments, and spent years trying to get rid of it. And just this year, finally managed to replace voluntary health insurance, trying to say that voluntary health insurance, just banning it is not so straightforward, is not maybe legally possible, but by removing co-payments entirely and instead coming up with a public levy. And as I think I saw someone in the chat mention as well, once you do that, you have a new revenue source that can be pooled at the Ministry of Finance level. This can be redistributed much more easily. It's much more efficient. So I think just to say that while voluntary health insurance in these cases, in the case of France, in the case previously of Slovenia, Croatia, maybe Belgium, as we'll hear a little bit in a second, there is another way that you can rely on public funding, create new funding sources, new levies that are more efficient, that can be made to be more equitable depending on how they are levied. Although in the case of Slovenia, I believe it is a flat contribution that is not income based. I'm going to go to Damien really fast. We're running short on time. Sorry, Nicholas. Damien, thank you for your previous intervention. I'm going to go to Nicholas for very quick. Just a sense of the priorities in Belgium. Where are things going? Where are things going now? What is Belgium trying? I think Belgium, at least from my view of the three, is the most complicated of the countries. What is the priority going forward in terms of improving financial protection?
So yeah, there always been political efforts to improve affordable access to care in Belgium. It's an important policy debate. If you ask me how is the way forward, so I think that in one way gaps in service coverage need to be addressed, and that's something that has been done in the last couple of years. For example, dental extractions, dental exams are now covered for more age groups than before. Also, the public health insurance is trying to cover optical care better, and it reduces the need for like complementary health insurance. So that's a good thing. Secondly, as I already said, balance billing is a really important issue in Belgium. And there are initiatives to stop or reduce balance billing in outpatient care and really exempt people with reduced co-payments from it. But this reform, of course, that faces resistance because dentists and specialists, they threaten that they'll stop accepting these patients because they can't provide quality of care without the balance billing. At least that's what they argue. And third, a really important reform that is going on already for a couple of years and that will likely continue for years is reform to the hospital financing. Balance billing and hospital financing are closely connected because it's really prevalent in inpatient care. And this reform is the unique chance to structurally change the role of balance billing in hospital care and might be our way out of the system like it is in Slovenia.
Great, thanks, Nicholas. I know we are so bad on time. So I want to thank the three of you. I mean, I think the takeaway message, to me at least, from this session is that all countries are going to be rationing, but you can ration in a way where, with financial protection in mind, where you ensure that, especially if we go back to the first slide of the morning, with the lower threshold that we hold poorer households to compared to richer households, by prioritizing poorer households, recognizing that they really cannot afford to spend very much, if anything, out of pocket, progress is possible to try and improve financial protection, even with fixed resources. I think, Sarah, do I pass it back to you for a brief
Yes.
close, and then to Katja? Thank you.
Thanks, John, and thanks, everybody. I think, Clementine, can you just give me the next slide? Can you give me speaker rights, Clementine, so I can just move it on? Oh, perfect, thank you. So just in summing up, in the report that we have, the work that we've done, we identify these 5 coverage policy choices that we think that countries, that we encourage countries to avoid. And some of you we've discussed almost all of them here today. Some of you may be wondering why it is that countries actually make these policy choices. Why do countries do these things if they're not linked to evidence, or if they have these detrimental effects on households and so on? Is it that countries don't understand the evidence, or is it that they ignore the evidence? I think one of the things that we do see across countries is that there is an element of what we might call path dependency. So for many countries, things happen because this is the way things have always happened, and you're on a path, and it can be very difficult to make a change, to change the way you think about things. But I think what we've seen very clearly from our speakers today, and I want to thank Damien and Nicolas and Rosa for their excellent interventions, what we've seen is the role of political choices at play in health systems. And this means that progress really is possible. When you have political will to make the right choices, it is possible to make progress. We've also seen that none of these countries is perfect, but what they do have in common is a recognition of the gaps that they have, and there's a clear direction of travel in which they want to go. I think they also all have a focus on trying to protect the people who most need protection, and I think that's an important lesson for other countries in the region as well. So I will just bring the technical part of the webinar to a close with that, and hand over to you, Katja, for your closing remarks on behalf of DG SANTE.
Thank you very much, Sarah. You summarized very well in a very nice way this very rich discussion, and I would like first of all to thank the WHO colleagues and the experts who could join us today and share their experience of excellent ways of addressing in a very proactive way actually gaps in access to healthcare. And I fully agree with what Sarah said, that the most important step is actually to admit where the challenges are, where we stand in terms of solidarity and fairness of health systems. Then we can discuss how to address these challenges. And I hope that this policy dialogue inspired good solutions. I would like to say that this dialogue showed that there are very different ways to ensuring solidarity and fairness in health systems, but there are some universal policy messages. It is very clear that we have to ensure financial protection measures in our health systems. Otherwise, we will see a problem of shifting the burden for paying of healthcare on certain parts of population. Yeah, we could hear about shifting this burden from pensioners to working age people. But also, yeah, we should remember about those who are completely uncovered, who fall through the cracks because they are not part of the healthcare coverage. So certainly these gaps in health coverage will remain very problematic, and they will not lead us into the solidarity pathway. Especially in countries which have the entitlements linked to contributions. There was a little bit of the discussion, because still in such systems we can find the ways to ensure solidarity and the redistribution of health benefits, but still this is probably the solution which would not lead to the biggest redistributive impact of healthcare. And this dialogue also shows that a lot depends on the context-specific challenges in access to healthcare and on differences in health systems. But there is a lot of knowledge, and I was very happy that this dialogue allowed us to tap into this rich knowledge. And stressing once again, I would like to thank very warmly the WHO team for this very good work, which is super timely. And here we are very happy that on top of providing us more effective metrics of measuring problems in access to healthcare, this work is also actually very rich in inspiring policy solutions. And yeah, just the last word from me, somebody in the chat said very rightly that healthcare is a right, not a privilege. And yeah, I hope, yes, that this policy dialogue contributed to keeping this very important aspect in the heart of the European way of life. Because access to healthcare as part of the social protection is really key dimension of the European way of life. So thank you very much, and I also thank very much Clementine and Abigail, without whom this seminar would not happen. Thank you for facilitating this great debate on the HPP policy platform. Thank you all.
Thank you so much, Kasia. Thanks. I just want to close by saying thank you to all the speakers, particularly our country experts. Thank you, Kasia, for being here, and for Maya for being here earlier. Thank you, John. Thanks to Jorge for his presentation on UHC Watch, and he and Lean have been very active moderating the chat. Thanks to our EUHPP colleagues behind the scenes, Clementine and Abigail. And finally, thank you so much to all our participants for joining us today. All of the materials that we've used today will be available to you on UHC Watch afterwards, and on the EUHPP platform as well. Thank you so much for joining us today, and enjoy the rest of your day. Enjoy your lunch. Bye.
Thank you.
Bye.
Bye-bye.